So the last bit of this meeting is going through questions that people had actually submitted when they actually registered at any of the patient workshops around the country or even on a live stream. So now we've actually got two other health professionals. Oh, thank you. So we have Dr. Matthew Silsby, who's a neurologist who works in the Westmead Amyloidosis Clinic to help out with some of these questions. And I also have Dr. Alison McLean, who's a genetics specialist who works in the Westmead Amyloidosis Clinic. And of course, you already know Ellen, who's a specialised nurse in heart failure who works in the St. Vincent's Amyloidosis Clinic. So essentially, we received 20 questions. I think people were very shy, wondering what to do with these questions. So about a 50-50 split from people who had light chain amyloidosis and those who had TTR wild type, but a significant, 10% from people with hereditary amyloidosis or their family members. So we've chosen just to divide them into different types of amyloidosis disorders, if you will. And so I think some of these have actually already been answered. So I'll read out the ones that I'll ask our panel to address. So maybe I'm actually going to ask the second one to Dr. Matthew Silsby. What are the various symptoms associated with, now this is a very old acronym, familial amyloid polyneuropathy. So hereditary amyloid in people who actually develop the nerve symptoms first. Can you actually then develop heart trouble from your hereditary TTR amyloidosis? And will heart involvement eventually become an issue? Do I need to worry about this? Can it be severe? What can I expect?
Jump in, okay. So neuropathy is, the suffering of the nerves is what the word actually means, because pathos is suffering. And so it can be anything from just pins and needles, numbness, burning, pain. It can be poor balance with no other real features. And then it can develop into weakness. And the commonest pattern for neuropathy is to involve the longest nerves first. So it's the nerves that go all the way down to the toes at the very beginning, and then it works its way back up the leg. You think about hand involvement in the same sort of way. You can get some symptoms in the fingers and the hands at around about the time that the nerves are reaching the knees, because the hands by your side are about that long as well. And then there's also the autonomic nervous system. So that involves maintaining your blood pressure, managing bowel function, accommodating your pupils to light, emptying your stomach. So anything that can go wrong in those realms as well is classified as neuropathy in this condition. Some hereditary or familial forms of TTR can affect both the heart and the nerves. Some affect predominantly the nerves with very little heart involvement at all throughout, and some primarily the heart. So it's not a straightforward question, I guess. I think
it's difficult.
Heart involvement might become an issue, and it's certainly something that we check for at every clinic visit. We're checking for all of those symptoms I just listed, as well as any cardiac symptoms. And then if there is any sign of that, then we initiate those investigations in a more targeted fashion.
And it's reassuring that there's now treatments for people with hereditary TTR with nerve disease, because they're effective treatments that we've previously discussed, and so hopefully the chances of getting heart disease are far lower than they were in prior years. So when taking, now on Patro is the brand name for patisiran, how can I get news from my doctors to know it might actually be working? Aside from me feeling better, what are some of the things that I can ask my friendly neurologist? Can you prove that this is working aside from me just feeling better?
For the most part, that's all I really care about. Is
Yeah,
if you
me
feel
too.
better.
Who cares? You're better.
Who cares? Yeah, exactly. If you feel better and you've got better function and you've got better balance, then that's a win. I don't think we need to prove objectively
No.
that it's working. I think if it seems to be helping, then we just continue. We do perform nerve conduction testing, but those changes can sometimes not quite match the clinical state anyway. They might be delayed. So it's a helpful tool to do nerve conduction testing on a semi-regular basis. And then you can look at those trends over time and say, look, things are very stable and we would have expected much worse than this by now. Some people do get some improvement on those tests. So it doesn't really, I don't mind. Just, if it feels like it's working, then we'll just
You're
keep
the better
using it.
gauge than the tests. I mean,
For
no,
sure.
no offence to neurologists testing tools, but you honestly are.
I think all good clinicians think that way, though. I don't think that you should be relying on your tests. I think you need to listen to the person reporting their symptoms, and if there's a benefit, then I think we can keep going.
Yeah. So the next two are actually for Alison, our genetic specialist who's joined us. So when do you recommend family members get the genetic test?
Yep, so that's a very good question. So it's a very individual decision as to when people get testing. So as I mentioned in my talk, there's two types of testing. So there's diagnostic and predictive. So if someone is diagnosed as a late onset and they have siblings who may be symptomatic, then they should probably get testing done pretty quickly because they're on a diagnostic journey. But if we're talking about the at-risk children of an individual that has just been diagnosed, well, it's very individual, and I think people should be referred to their local genetic service to have a discussion about whether and when the most appropriate time for them to have testing should be, because the decision is very individual, and we won't see people as families together because the family dynamics are complex. We will not see siblings together and do it as a job lot. They have to come individually. And people have lots of different reasons for and against testing. So it's the time that I guess suits them, what's best in their life and the journey that they're going on. The other thing to know is we will not test children under the age of 18 for this, okay? That is any genetic condition where there is no symptoms under the age of 18 and it's not going to change their management. There is a Human Genetics Society of Australia's guideline saying that violates the autonomy of the child, and so we won't do that testing, okay? So if you talk to your children about this and they're under 18, they can come and have a conversation, but we would probably defer it at that time. And also once they're over 18, I recommend anyone come and have testing done or even have a conversation with the genetic service. And really the other crunch point is when people are family planning. Now, I'm not necessarily saying you need to have genetic testing done before family planning, but if you do have a genetic condition or a family history of a genetic condition, then you probably need to go to a local genetic service with your partner to discuss what that means when you're having children, just so that everything can be cleared around the inheritance and the risk and what that means.
It's a very complex topic, isn't it? But you handled it really well. So what kind of psychological counselling support can people expect or ask for in Australia before they get their gene testing?
Yeah, so I mean, in Australia we're lucky, so we have genetic counsellors, and they're really good at all the psychosocial support around genetic testing, and they're an extremely good resource, and they will talk you through all of the pros and cons that's individualised to you, as well as the complexities of testing and inheritance. And there are also lots of genetic resources, and I had that on my last slide, including the Centre for Genetics Education, Genetics Alliance Australia, and also other companies and foundations which are around kind of genetic conditions as well that are very useful for this and patients. I mean, I imagine the AAN would also be very useful.
Probably not as useful as those websites, to be honest.
Yeah.
But there are so many genetic clinics actually around Australia, which is fantastic, with counsellors embedded in them.
That's right.
Yeah.
And if you go to genetics.edu.au, there's a genetic service finder there, so that will be able to tell you what your local genetic service is.
So I'll move on to some of the questions from our patients with light chain amyloidosis. I think I'll have to tackle these ones. I would like to know whether it's possible to have had AL amyloidosis over a period of many years, accumulating damage bit by bit, or whether it can only hit relatively quickly. Both is the story. So I think I know why the question occurred, though. There is a difference in general with how quickly the light chain amyloid can make you sick versus those who have the TTR amyloid. So in general, when the process starts, it's generally quicker than those with TTR amyloid. So we know that those with wild-type TTR amyloid, about 15 or 20 years before it goes to the heart, it can go to the carpal tunnels. So, and just be silently in the body building up. Whereas in AL amyloidosis, it's definitely not a 15-year lead-in, where probably it's when it starts making the amyloid in your body, the light chain amyloid, it's probably within 2 years that you're feeling symptomatic. So that's a general thing. But there's a lot of what we call variations. So you can actually have people who just haven't read the textbooks. And that's just biology for you. So what are my options when my light chain amyloidosis is returning? As you heard before, on Medicare, you can now get daratumumab with other treatment because if you're newly diagnosed, because it's been proven to be so good. But there isn't anything actually on Medicare for when it starts coming back. So I think I'd already answered a part of this. So I think go to your doctor and say, look, are there any clinical trials? Because yes, there are, as I mentioned before, for people where the amyloidosis has come back. Also, you may actually happen to have a mixed type of disorder. Some of you may have been told that you fulfill Medicare criteria for a related disorder called multiple myeloma. So remember all of those Medicare criteria. Some people with AL amyloidosis actually happen to tick all the boxes for this related disease. And so you may have had very confusing clinic visits where the hematologist saying, oh, remember I'm telling you have myeloma? I'm just going to tick this box. For when your myeloma returns, you can actually have the drugs to switch off the same cell that's making your AL. And I know it causes a lot of confusion, but that's why some of you may have heard that you also have myeloma, dare I say. I think I'm actually going to go straight to the bottom question. On the page. So this may be hard for you to answer, Matthew, but can nerve damage get better? And in light chain amyloidosis, and if you want, you could comment on whether you've seen it get better in transthyretin amyloid.
Yeah, it is difficult to answer. I think it does depend on the degree of damage, because nerves are very protected little organs in the body that don't get very good blood supply and don't have a very large amount of reserve for recovery. They can very slowly recover if the thing that's causing the dysfunction is taken away. So if you're treated for an amyloidosis and the amyloid and light chains and all, the misfolded proteins, if they're all out of the system because you've been so effectively treated, the nerves can slowly recover. And we've certainly seen people gain back some function that they lost, but it tends to need to be either early on or very mild and not actually have left lasting damage. And there's a difference again between the testing and the clinical feeling of it. You can have some disorganization of the nerve signals and you can feel very off balance because things are not quite getting back up to the brain properly. And then you treat it and that sort of thing starts to feel a lot better. But the nerve fibers themselves may not have changed all that much on the testing. If there's very minor changes on the nerve conduction testing, we can see some things bounce back as well. But then on the other side, if things are severe, you've got severe weakness or really dense patches of numbness, or the test results are coming up as no response, it's almost impossible to get that sort of function back because the fibers themselves have been so badly damaged.
So this is our last page of questions from the people with transthyretin amyloid, non-hereditary type. Is there a better treatment than tafamidis or Vindamax? That's a brand name for ATTR. And I guess the second one I can answer. These are very leading questions. I'm just wondering, Ellen, if you would like to tackle that first one.
I can tackle it very briefly.
Yeah. It's a whole conversation, like another hour, and we're already 10 minutes over.
That is a big word. I will just say that available in Australia currently, no. Tafamidis or Vindamax is the only option. As Fiona spoke to earlier, there are a number of clinical trials and some newer agents that are hopefully going to become available in the near future. So
they're
watch
promising.
this space.
Yeah. So this is an interesting one that I've kept in there. Are there more patients being diagnosed with multiple myeloma along with age-related TTR? I think because awareness is increasing, the short answer is yes. There are patients who could have several types of amyloidosis, and we are seeing that more because people actually, thankfully, around the country, thinking and coming to educationals like in the next room and thinking about amyloidosis more.